Okay, so I think we are live and we are on both TikTok and on YouTube. So lower back pain and pain in the leg, what we call radiculopathy, is a very common symptoms. As a matter of fact, by the time you're 50 years old, there's only 30% chance you don't have spine problem. 70% of the people have had or have some spine problem. And by the time we are 60 years old, there's only 5% chance that we don't have spine problem. And by the time we are 70 years old, that chance is only 2%. So this is a common problem. Now, what I tell everybody is that the spine is a living thing, living tissue, meaning that it actually repairs itself. And our entire process of spinal health is a battle between spine healing process and wear and tear of the aging process. And sometimes it's truly a tremendous kind of pathology that are clinically silent. So meaning that one of the things that I have learned over the years is never fix the pictures, always pay attention to clinical symptoms. Now, here we have a 70-year-old person who had for 1 year practically difficulty walking. We have a name for this process. We call that claudication. The word claudication comes from vascular word, because if somebody has like a vascular block or narrowing in the artery that get blood to our legs, especially when they exert, the ability to walk is reduced. That's called vascular claudication. So we neurosurgeons stole that from them. We call this process spinal claudication or neurologic claudication, where especially when people stand, walk, or exert, because of the pressure, more pressure that is exerted on the neural structure inside of the spinal canal, they lose the ability to practically communicate with the nerves that go to the leg. So pain gets worse, function of the nerve gets worse, function of the leg gets worse, and the ability to walk gets worse. Now, obviously, if we look at this picture here, we look at the so-called sagittal T2 of the lumbar spine. So practically, this is the sacrum L5, 4, 3, 2, and 1. This is front, this is back, this is up, this is down. This is a so-called, what we call axial view. At the same, you see the line here, we call that the cross-section. And practically, this is a horizontal slide in our back at this level. What you see here is obviously skin of the back, and in this picture here, the fat tissue is white, the muscle is darker, and you see the fat between the muscle fibers. And what you see here is that there is something here that is not exactly muscle. And that is, in this specific case, this patient had what we call decompression, had a macrodiscectomy, and this is some scar there. What you see here is the vertebral body, what we call transverse process, paraspinal muscle, lamina, and here you see what we call facet, the joint in the back that make two vertebrae connect together. This is the spinal canal, and I have to show you what a normal spinal canal looks like, but usually normal spinal canal, for example, if you would get it at this level, would be a round, and it is white, because white is fluid inside of the spinal canal, the so-called cerebrospinal fluid. And then the individual nerves would be like dots here, but all those individual nerves are cramped and compressed here. And here you see actually the herniated disc right there, causing what we call spinal stenosis, in this case, severe spinal stenosis. And that is comparable with the spinal claudication. Now, obviously, this patient has problem in other levels. That's practically not a single level is normal in this patient. as you see, here's L1, 2, 3, 4, 5, S1. Every disc is bulging out, but you see still some CSF sign here, meaning even though this disc is bad, to a point that even the end plates we call change. Now a spine, the disc is like a tire of a car that cushion the car against the road. And here we see, imagine you drive on a flat tire, the rim as well changes. And here you see the white edema inside of the bone. Now, even though the vast majority of the stenosis is here, if we would look at here, generally the nerve that goes down to comes out the next level passes exactly here. There's something important about the topology of the nerves. Between two bone, there is a disc. Just next to the disc, there is a hole where the nerve is coming out. By the way, these lines are the nerve. Those nerves, we call them nerve roots. And practically, the nerve root that comes out here is L5, L4, L3, L2, and L1. And they go top to bottom, practically to the thigh, outside of the thigh, back of the thigh, to the toes, back of the thigh, to the heel. But important fact is that they almost pass down here just above the disc base, meaning the L5 actually doesn't exit exactly where the disc is, but a little above it, just below what we call pedicle, where the back and front of the bones are connected. What that means? That 8 out of 10 times, if you have L5 symptoms, it's not the L5 S1 disc that's pushed on that, but the L4-5 right when the nerve passes to come out right here, we call that place lateral recess. So practically, if you have L5 symptoms, you should more look into the L4-5 disc space rather than L5-S1. And that is even more important because the L5-S1 here, this is where the L5 comes out. Still, it can be more pushed by a process in the lateral recess, the level above. So, having said that, let's look at the rest of the anatomy here. Here we see aorta, because of the higher pressure is round. This is vena cava. So this is at L3-4. They're about to split to iliac arteries and veins, okay? So let's look at the next level. So this is a CAT scan of the cervical and thoracic spine. Now, let's start with the thoracic spine. Obviously, this is a CAT scan because the bone is so crisply visualized. This is the sternum, the in front in the midline sternum. This is heart and the major vessels. First of all, when we come out, then we come down here, all of a sudden you see one bone is not completely visualized. When you see anything like that, you almost certainly know there is a side bending of the spine. What that is we call that scoliosis, when there's a side bending of the spine. Additionally, you see a metallic object here. This is an electrode of a spinal cord stimulation device, and you see it has small plates that are stainless steel, and you see these horizontal lines, which is practically a metal artifact, so-called streak artifact, and you see them that going horizontally, and that has with the that has to do something with the physics of how these pictures are produced. Now, looking at that again, this is CT. It's very different than MRI. This is the skin of the back, and then the fat has low density. That's why it's darker. And obviously, bone has higher density, and the muscle density is between fat and the bone. And you see that the rugged edges of the discs here, this patient has degenerative disc disease. And if you look carefully, you see actually in the front, some of the bones are growing together right here. And that sort of bone bridges in the front And sometimes it happens in many levels. And then we look for some genetic disease like ankylosing spondylitis or dish, disseminated interdiscal calcification and so on, and fusion. But in this case, practically, it's really limited to upper thoracic region. Now, this is a CT of the cervical spine, and you see the bottom of the head and the brain. And something that you see here again, this is the old kind of amalgam plumbing of the teeth. You see the streak artifact, and that as well tells you which direction the original CT data were obtained. Now I'm coming down. Here's the nose cavity, sphenoid sinus, medulla oblongata, cerebellum, the tonsils, cerebellar tonsils, skin of the back, again, fat under the skin, muscle, spinal processes. White is actually CSF, but CSF isn't usually white. The reason this CSF is in white here and here is because we put some contrast. So this is a myelogram. And then you see as well here that many of the vertebrae in the front, they're developing osteophytes or bone spurs that are growing together. And then you see here that in some areas, actually CSF is cut off, especially here. You see CSF sign all the way here and here, but it cuts off in 2, 3, 4, 5, 6, and 7. And that is a spinal stenosis in that segment. Then obviously you see the larynx, even epiglottis you see, and the trachea, and the other the bronchial tree, some of it is visible here. This is most likely the arch of the aorta. So let's see what else do we have today. Now, this is an interesting case. This is, again, this is the CT of the lumbar spine after we have given contrast. That is a myelogram, post-myelus CT. That is why CSF is white. This is the lat or so-called sagittal view, and the curvature you see here, we call that lordosis. It is normal. We have even some parameter we can measure it. This is a front view of the spine. Any side bending in the front view is not normal, and we call that scoliosis. And here I'm trying to measure that scoliosis between certain segments. And this patient has a double scoliosis. And more important, and even more technically demanding for surgery, is that not only that this is side bending, but as well the bone itself. This is the axial window, axial sequence. The bone itself is rotating. Look at the spinal process here. This was supposed to be coming straight down. So patient has a 31-degree rotation of the vertebral body, where practically the whole bone is turning to the side. That has consequence in the surgery because that makes the trajectories and anatomical consideration much more difficult. Now, let's look at a few things. This is the side view, and you see this dark here. Another place that you see dark in this picture is right here. And that is practically our bowel or rectum or colon. But decomposing the stool create gases, which are here. Now, this is as well gas, but different gas. This is not the bacterial decomposition, but the mechanical decomposition of the cartilage. Literally, the cartilage are made of proteins, and through mechanical decomposition, the nitrogen of the protein releases, and literally, that's what you see here. Having said that, if you look at this very carefully, you see that practically the discs are gone. This disc is okay, and this disc is okay, but practically no discs in other level. And I hope it makes sense that, in this level where the disc is completely almost gone, there's no more gas produced because there's no material left to mechanically decompose. And obviously the discs can collapse in a different way. They don't have to collapse in the same way on each side. And that is what the degenerative scoliosis come from degeneration of the disc unequally on each side, where practically one side collapses more than the other, and that leads to scoliosis. Usually it starts at a certain point, and then our body tries to compensate by bending to the opposite side, and that is why you see this double scoliosis often. So let's look at this. This is as well very interesting case. This is the so-called MRI of the thoracic spine in the in the T2 sequence. And here's the back, here's the front, this is up, this is down. You see the individual vertebral body here. And then all of a sudden, this level, that bone is completely collapsed. What's important here is that in the T2, you see this is collapsed, but it's not different or more wide than the rest of the bone. What that indicates often is that this is not this did not happen in the last few weeks, because that usually would cause edema in the bone, and then that would be white, the whole tissue would be white. One of the rules that I tell everybody, never make a decision based on one single picture. So you have to look at more pictures, and there are some other sequences beside T2, like STIR sequence, that are more sensitive to find if that fracture is new or old. Now, the way we measure the fracture, we measure the levels above and below divided by 2 and see what percentage of that value that we find by averaging level above and below is this one. In this case, I would say probably that's a more than 80% compression fracture, wedge fracture of the vertebral body. And because it's collapsing more in the front, a patient is almost jackknifing. We call that hyperkyphosis, meaning the patient is bending more forward. In some cases, this can be so bad that it actually limits the cardiac and pulmonary function. Again, you see the aorta and the shadow of the heart, but these pictures are made to have the best view of the spine, so they are a little less accurate for other pathologies. Now, let's look at this picture. This is a little more crisp picture, and the way in MRI to get more crisp picture is have a higher magnet. And probably the previous MRIs were at 1.5 Tesla. Probably this is a 3 Tesla coil that gives you more crisp picture. Another way of getting better picture is giving it more time. Practically, we put the patient in a gradient the magnetic field. We give a certain amount of energy at certain frequency that only help the proton at that location resonate, and then we listen like a radar. We send a signal and listen back. If you send more signal and listen longer back, you get crisper picture. But that makes the procedure, the MRI, much, much longer. Regularly, MRI are somewhere between half an hour to an hour. But with a high Tesla magnet, you can have much better picture quality in the same amount of time, or get the quality of the 1.5 Tesla in a shorter amount of time. So these pictures are crisper. So this is a higher Tesla magnet. And again, we see the sagittal and axial pictures, skin of the back, spinal process. You see the individual nerves coming down, and you see there's a disc herniation here, the little disc bulge here, and another disc herniation here with spinal stenosis. Now, if you remember the previous picture here, very similar, but this patient had only claudication. So in this patient, I treated only this level, where it gave patient this spinal stenosis symptoms. In this patient had quite significant radiculopathy, meaning the nerve that was going down front of the thigh, side of the thigh, and back of the thigh, all were involved. That indicate that this level, and this level they're all symptomatic. Even though the stenosis is only this level, and yes, this patient had as well claudication, I treated patient's symptoms. This patient required minimal invasive decompression and fusion of all these three levels. Now, what is the significance of that? The significance of that is that, when I first scrubbed in a one-level fusion, that was 7-hour surgery. You can imagine if you do a 3-level, that would be a very long surgery and not really beneficial to the patient. Because this long surgery is very bloody and practically it caused too much damage and too much blood loss. Recovery will be very difficult. Now, I just did that surgery today, one-level fusion, that when I was training, it was 7 hours. I did it in 35 minutes, 2 hours after the surgery. No, 2 hours after I left the OR, actually the floor in the hospital called me that the patient wants to go home. So doesn't want to wait anymore. So we have come such a long way, meaning that a surgery that was 7 hours is now half an hour a day surgery. So this surgery that was impossible, it just when I started my practice, because that would be too much blood loss, too damaging for the patient. This is a 1.5 hour surgery. A patient go home within 24 hours. So we can now concentrate more on patient's need when we are giving patients option, and less on the technical possibility of the surgery. So again, here you see it's fluid. The white is fluid inside of the facet or this joint. Now, I'm sure you have heard that, sometimes people have fluid inside of their knee joint or hip joint. These facets are joints, and inside of them, the fluid can accumulate, and that is what you see here. So this is yet another patient who have what we call almost grade 2 L5 S1 Spondylolisthesis. Let me explain what that is. If you look at this picture, again, axial and here and sagittal T2s, because CSF is white, in T2 CSF is white. And what we see in a regular level, you see the back of the bones are aligned here and here. They're all aligned, but when you get here, the back of this bone is here and the back of this bone is here. And so practically this bone is falling forward. If you look carefully as well, this bone and this bone are not aligned. The back of this bone is here, the back of this bone is here. So since this falling backward, we call that retrolisthesis. Since this falling forward, we call that anterolisthesis. So this patient has L4-5 retrolisthesis grade 1 and L5-S1 grade 2 anterolisthesis. And the numbers come from what percentages? If it's less than 25% of the depth of the vertebral body is grade 1, if anything more than that is grade 2, 3, 4, based on, is it 25% slippage, 50 or 75? Obviously, it is rare to have grade 3 and 4, because then practically you have a complete dislocation. They are mostly traumatic after car accident and so on. And those patients have severe deficit, because as you see here is the spinal canal and the nerves are passing through. Most of the time, I would say probably 70 to 80% of the time, the only way this can fall to a grade 2 forward is when the front and back of the bones are not connected. Some people are born with that. We call that so-called pars defect, where back and front of the bones are not connected. So what happens is that the bone is literally falling forward. And that obviously can cause significant back pain, leg pain, deficits, and so on. And in this case, obviously, we go and try to realign this as much as possible. This is what I do. I take the bad disc out, I put a spacer in, I try to realign it as much as possible, and then I make sure it doesn't get worse. What you need to know, and it's very important for spondylolisthesis, that this happened over possibly tens of years. The nerves are already adjusted, and sometimes patient have not much symptoms in the leg. It's just the back pain that's bad, but sometimes as well they have back pain and leg pain. Now, when I was much younger, and many younger surgeons as well today, they want to make that picture beautiful. They want that bone exactly here. To do that, sometimes you have to do tremendous amount of bone work, break the bone, realign them, and that by itself is it can be very invasive procedure. Now, what I've learned over the last 10 years is that, you don't need to correct the spondylolisthesis to take patient's symptoms away. You just have to make sure the bones are separated and the slippage doesn't get worse. For most of the cases, I'm able as well to correct that with minimal invasive. But now the difference between trying to make the picture look good, which is an 8-hour surgery or 5-hour surgery with a half a gallon of blood loss, and my surgery, which is a 40-minute, 50-minute with the 1/5 of a cup of coffee blood loss. And they give me actually better clinical result because I don't cause too much damage to get the job done. Often to do this surgery as well, we go from the front. We call that anterior lumbar interbody fusion, where we go from the front, open up the belly, and approach the bad disc from the front, take it out, put a huge spacer in, and then we put screws in. Most of the time, I used to go, and most of people still go from the back. So go from the front, open up the belly, take the bad disc out, put a spacer in, put a screw in from the front, then close it back up and turn the patient on the back, on the belly, and then as well from the back, put screws in. This is a whole day surgery, and they're not rare. This is not a rare occurrence that somebody dies of the vascular injury when they go from the front. This surgery totally depends on the access surgeon, vascular or general surgeon who give the spine surgeon access to the front of the bone. Once you are there, the job of the spine surgeon is really minimal compared to getting the access. And now if you have a good access surgeon and you get access right away, it's a fantastic surgery. But if the surgeon needs hours to get you there and damage few vessels on the way in, that this surgery becomes a deadly surgery. The advantage of what I do, and I have done all these surgeries, is that first of all, I can do all from the back, avoid the vessels in the front, but as well, that it's much faster, much more efficient. The disadvantage of what I do, the spacer that I put in is much smaller. And for that reason, sometimes, even if the problem is the L5, S1, I go one level above to distribute the weight to have a better mechanical device. So not to maximize, especially you see that here, you see the angle of L5, S1, there's a lot of shear force here. So if you have a smaller kind of spacer here, the shear effect may be too much for that smaller size spacer. So in many cases, when we have a grade 2 spondylolisthesis L5, S1, I go one level above. In this case, you would be going up anyway because patient had symptoms and there's a herniation, there's a listhesis there. But even if the level is normal, I still sometimes do that. Now, I just got into a small little fight with somebody, a surgeon, a younger surgeon on LinkedIn that says, oh, you shouldn't be doing that. You should only going from the front. Well, that is a 7-8 hour surgery and people still die of that. But as well, he was saying that you shouldn't sacrifice a normal disc above this here. Well, I don't see it as a sacrifice. I see it as ensuring that the result of the surgery is adequate by distributing the weight from L4 to S1 and avoiding all the complications that you can get from the anterior approach, and as well making surgery a lot more efficient and faster. By the way, this concept that if mechanical stress needs to be distributed, going many levels above and many levels below wouldn't be anything unusual at all in spine. That is actually a routine. As a matter of fact, you remember this picture where you have a compression fracture. The recommendation is, if you're going to fix that, especially in somebody with soft bone, don't go one level above, one level below. Go 3 levels above, 3 levels below, because anything short of that is going to fail. Most of surgeons do that, and we don't see that as a sacrifice. We see that as mechanically stable construct. With my minimal invasive approach, often I'm able to go just one level above, one level below. If the bone is very soft, only 2 levels above, 2 levels below. But I rarely go 3 levels above and below as it's recommended for open surgery. So we covered a few things here, and I'm going to actually, this is half an hour, has been half an hour. And this is going to be the last picture I show. And you remember we talked about this picture where the spine was very narrow. And that space here was very narrow. We call that stenosis. Now, this is a myelogram of the spine. And you see here the dots. These dots are the nerves farther down here. When we are born, our spinal cord goes all the way down to our tailbone. Our bone grows faster than the nerve. So by the time we are an adult, the spinal cord actually stops at L1, L2. So here is where it stops. The rest are only the nerves that go down. And those nerves, when the people who did anatomy opened it up and put it on the table, it looked like a tail of a horse. For that reason, we call that cauda equina, Latin for tail of a horse. And that is what you see. These dots are individual nerves that goes out. They go out between these bones. Each of them go to a certain area in our body. Again, this is the paraspinal muscle. You see the kidney here, some bowel. Here you see the aorta. Vena cava is more flat here. Here is the iliopsoas. And here is part of the pelvis bone is cut off here. Here you see the contrast in this post-myelogram CT, and you see patients laying down on the back. So patient is laying flat on the bed. That is why this contrast is pulling down here, but some of it is mixing. That's why you can see the contour of the nerve. And that's why we do this. Myelogram is vastly, for me, preferable to MRI for most of the things I do. Number one, it has less spatial torsion and distortion. Number two is that the density of the data on a CAT scan is much, much more. What that means, the regular grid of an MRI is 256 times 256, but the regular grid of the CAT scan is 512 times 512. So by original picture, the density of the information is 4 times more, 256 times 256 is 1/4 of 512 times 512. But as well, it shows me the bone and if I give contrast with the myelogram, the soft tissue beautifully. Whereas MRI wouldn't really be good for metal hardware or a bone as CT is. So I'm going to stop here. We've covered a lot of material. And again, this is mostly spine-specific material that I'm putting out there. This will come online on YouTube. And so if you have questions, add it to comments, and I can return to that. If you have a question, put the minute and the second of the picture provided, and with the specific question, and I try to do my best to come back to that. Otherwise, I wish you all a very happy weekend. Enjoy your weekend, and we see you in 2 weeks with another case review of the IS Life. Thank you.